Hello everyone, welcome to Diagnose It. So now let's discuss our new case. So the acute symptoms of the disease include hepatomegaly, right upper quadrant abdominal pain, nausea, vomiting, and ascites. The chronic symptoms include sequel of cirrhosis, portal hypertension, including the varicose bleeding, ascites, spontaneous bacterial peritonitis, fatigue, and encephalopathy. The diagnosis of the disease is often made using the ultrasonographic evaluation of liver and its vasculature. Also, the cross-sectional imaging, which are obtained using the CT scan and MRI, are also quite helpful. So, based on these facts or information, we can say that it is a disease which is known as the Budd-Chiari syndrome. Budd-Chiari syndrome is also known as BCS. So, what is a Budd-Chiari syndrome? So, it is basically a hepatic venous outflow obstruction. It is quite an uncommon disorder, and the primary causes for this disease include the obstruction, which occurs mainly due to thrombosis or due to the phlebitis. So these are the main primary causes for the development of Budd-Chiari syndrome. So now, seeing the basic anatomy, if we see the normal anatomy of the liver, then the liver receives its blood supply from the hepatic artery and from the portal vein. As we see in the diagram, hepatic artery and portal vein. Now, the blood from the liver, it leaves it through the help of the hepatic veins, which are three number: right hepatic vein, middle hepatic vein, and left hepatic vein, which further drains the blood into the inferior vena cava. So any obstruction in these veins, as we can see the right hepatic vein, middle hepatic vein, and the left hepatic vein, and also in the inferior vena cava, will lead to the development of the Budd-Chiari syndrome. So we must keep in mind that any obstruction in these veins leads to Budd-Chiari syndrome. But an important fact is that there must not be any correlation between the obstruction and the pericardial diseases. The obstruction must not be due to any pericardial disease or heart disease. Pericardial disease or heart disease. So this was the basic introduction about the Budd-Chiari syndrome. So now let's talk about the causes which leads to the development of the Budd-Chiari syndrome. So the first one is the myoproliferative disorders. So these involve the cancer of the blood. So cancer of blood, which basically occurs due to a defect in bone marrow. The most common myoproliferative disorders are the polycythemia vera, polycythemia vera, and the thrombocythemia. Thrombocythemia. So these are the two most common myoproliferative disorders. And what happens in these? That these disorders are accompanied by hypercoagulability. Hypercoagulability, in which the chances of the formation of thrombus or the formation of any obstruction increases in the body. Second one is the malignancy. So the malignancy constitutes about 10% of the cases which of the Budd-Chiari syndrome occur due to the malignancy, whereas the myoproliferative disorders are responsible for almost the 50% or half of the cases of Budd-Chiari syndrome. So in malignancy, what happens? There is the direct compression or invasion of the vessels. There occurs a direct compression of vessels. Direct compression of vessels due to any malignancy vessels. Along with the compression, due to any malignancy, there occurs the development of any hypercoagulable state, which leads to the venous obstruction or venous thrombosis. And the most common cancer which is related to the Budd-Chiari syndrome is the lung cancer. Most common cancer is related is the hepatocellular, or we can say that the lung cancer. The hepatocellular cancer is both the primary cause as well as the secondary cause for the development of Budd-Chiari syndrome. So the third one is the lesions of the liver. So in case of any infection of liver, it leads to the compression of the vasculature. For example, in the cases of the hepatic cyst or any adenoma. So these are some of the basic lesions of the liver which lead to the development of the Budd-Chiari syndrome. So now the fourth one is in case of pregnancy and due to the intake of the oral contraceptives. So what happens in these cases? These leads to the development of hypercoagulable state in the body and are responsible for the 20% of the cases of Budd-Chiari syndrome. So in pregnancy and in the intake of oral contraceptives, the chances of development of Budd-Chiari syndrome increases. Then the next one is the idiopathic cause, which account for the 20% of the cases of Budd-Chiari syndrome, and it occurs due to the deficiency of protein C and antithrombin deficiency. So this was all about the causes. These were some of the main causes which leads to the development of Budd-Chiari syndrome. So now seeing about what happens in Budd-Chiari syndrome or the pathophysiology of this Budd-Chiari syndrome. So if there is obstruction of one hepatic vein, then it is known as the silent Budd-Chiari syndrome, because it is not that much severe form. But if the obstruction is in more than two hepatic veins or two hepatic veins, then we'll see what happens. So due to this, the occlusion of hepatic vein occurs, there occurs the venous congestion, which leads to the stretching of the liver capsule. The stretching of liver capsule then further leads to the dilatation of liver sinusoids, then which leads to filtration of the interstitial fluid, and hence the congestion of liver occurs. Now, another thing which should be kept in mind is that when these filter fluid, it exceeds the capacity of the lymphatic system to drain it, then the fluid starts passing through the liver capsule and it goes in the abdominal cavity and leads to the ascites, which is one of the three classical triad which is seen in the Budd-Chiari syndrome. And due to the formation of thrombus or obstruction to venous outflow, the portal venous hypertension develops, and hence the blood flow decreases to liver via the portal vein. So portal hypertension is also common. Portal hypertension. The most common lobe of the liver which is affected in Budd-Chiari syndrome is the caudate lobe, because its blood is directly shunted in inferior vena cava. So when the hepatic veins are occluded, then the hypertrophy of the caudate lobe is seen. So this was all about the pathophysiology of Budd-Chiari syndrome. Now let's divide the Budd-Chiari syndrome on the basis of the duration of the occurrence of symptoms. So first of all, it is the acute Budd-Chiari syndrome, and the second one is the subacute Budd-Chiari syndrome, and then the last one, the third one, is the chronic Budd-Chiari syndrome. So in acute Budd-Chiari syndrome, the symptoms developed only in a few weeks. Only in few weeks. And the most common symptoms are the hepatic necrosis and the intractable ascites. The venous collaterals are generally not seen in the acute phase. Now talking about the subacute phase, so the symptoms developed up to in the time span of up to 3 months. The specific thing about this subacute is that the venous collaterals starts developing, and a minimal ascites and hepatic necrosis are seen in subacutic form. In the chronic form, what happens is that the cirrhosis of liver happens, and the venous collaterals are also seen in this case. The fulminant liver failure can also occur in case of the Budd-Chiari syndrome. So now talking about the classical triad of the Budd-Chiari syndrome, so it basically includes the three symptoms, which are the abdominal pain, then the development of ascites, and then the hepatomegaly. So this was the classical triad. However, the symptoms of Budd-Chiari syndrome are also quite vague and non-specific, but the classical triad is consists of the abdominal pain, ascites, and hepatomegaly. So the other symptoms that include the development of the jaundice, as the liver function is affected. So the development of jaundice takes place in the body, development of edema, and stasis and splenomegaly are also seen. So these were some of the main symptoms of the Budd-Chiari syndrome along with the classical triad. Now, in which condition we can suspect that it is a case of Budd-Chiari syndrome, as it is quite an uncommon diagnosis. So these six scenarios, we can expect that Budd-Chiari syndrome can be a diagnosis. So in sudden onset of ascites along with the painful hepatosplenomegaly. Second one is the massive ascites along with the relative normal liver functions. Then the sinusoidal dilations, as we have seen in the pathophysiology in liver biopsy without any heart disease. So this was the key point in this. The fulminant hepatic failure along with the ascites and hepatomegaly. Unexpected chronic liver diseases with the thrombogenic disorders. So these were some of the common cases in which we can suspect that it is a case of the Budd-Chiari syndrome. So now let's talk about how the diagnosis can be made. So these four things are quite helpful in making the diagnosis. So first one is the Doppler's ultrasonography. So the Doppler's ultrasonography includes so in this ultrasonography we can see that obstructed hepatic veins. Obstructed hepatic vein can be seen. Then we can do the examination of the ascitic fluid, which will be very helpful for diagnosing the Budd-Chiari syndrome. As in the ascitic fluid, there will be elevated protein levels and also variation in the WBC amount. We can do some blood tests. However, these are not that much confirmatory, but we can do for the serum levels of the AST, serum levels of AST, ALT, and ALP, as the hepatic functions are liver is involved. So a liver function test assay can be used. Then we can do the liver biopsy. in the liver biopsy, we can see for the necrosis, hemorrhage, and congestion in the central zone of the liver. So these were some of the tests we can do for the diagnosis. Also, CT scan and MRI scan are also quite helpful. So this was all about the diagnosis part. So now at the last, let's talk about the treatment part. So in treatment, what are our goals? So our goals are basically to relieve the patient from the obstruction, relieve the obstruction. Second one is the correction of the underlying conditions, correction of underlying conditions. And the third one is monitoring the deterioration level of the liver, monitoring the deterioration of liver. So these are our goals for the treatment. So in the treatment, we can give the patient with anticoagulants. So in anticoagulants, initially the patient is given with heparin, and then it is slowly transited with warfarin, which is given for a very long duration. Then we can also give him some thrombolysis and stenting therapies. The surgical decompression can also be considered in acute forms. So this was all about the treatment part of you and all about the Budd-Chiari syndrome. Thanks for watching, and don't forget to like, subscribe, and share Diagnose It, and also do follow us on Instagram. Thank you.